Why do some doctors get paid more for the same treatment than others, even when they're in the same city? Well, chances are the doctors who get paid more have a solid payer strategy. What does it take to have one of those? My guest today helps his clients develop solid payer strategies, and he's going to tell us all about how to get started. I'm Carl White, principal at Market Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practice owners stay private. That's usually what they want anyway, but care is better when the providers of care are the ones who own the practice, because then all of the decisions about the practice, clinical, business, whatever, are made by those who are providing care, and that's just going to make sure that the patients are always first. My guest today is Adam Middleton. Adam has committed his entire professional career to healthcare, working at for-profit and not-for-profit hospitals and as a consultant to physicians and healthcare-related businesses. Since 2008, Adam has consulted with emerging businesses in leadership positions, physician practices, post-acute providers, and hospitals with a focus on management, operations, finance, and strategic planning. He has extensive experience in physician compensation, including contracting and structures. Through his leadership at Healthcare Advisory Network, assists hospitals and practices to determine fair market compensation and compliance issues that surround employment practices. Adam, thank you for coming on Practice Care. It's great to have you here.
Thanks, Carl. Appreciate you having me on.
Yeah, this is a topic near and dear to anybody's heart who takes insurance. So I'm hoping that we get more than the average number of listeners. But before we get into it, I want to start where I always start. Tell us more about you, your business. That was a pretty short bio, but that's what I asked you for. So fill in some gaps.
Okay. Thanks, Carl. Yes, I've been in the business for as long as I can remember. Actually started as a candy striper when I was in high school as a volunteer
Wow.
in a hospital. So always have loved healthcare and decided to go onto the business side of healthcare. Did medical sales for about 10 years. Was a hospital administrator for 10 years before
Yeah.
I jumped out and started my private consulting business.
Mm-hmm.
And as a consultant, I've worked with hospitals, physicians, healthcare startup companies, and healthcare entities, kind of
Mm-hmm.
run a full gamut of that,
Mm-hmm.
concentrating a lot over the last 5 or 6 years, really on that provider side, helping them really negotiate the ever-changing world of healthcare, and trying to make sure that independent providers, if they want to stay independent, give them those opportunities to do that. We work also with hospital-owned physician groups on efficiencies, all kinds of different areas, kind of the full focus that a healthcare consultant can jump into.
Yeah, we're going right to the belly of the beast with payers here. So maybe one of the top 5 reasons why you would continue to bang your head against a wall in what can feel
Mhm.
like futility. So hopefully we can clear some of the fog out. Let's get into it. Let's just start with some basics. When it comes to like the practice side, so you're on the provider side now, what are the main areas of concern when it comes to payer contracts? It almost sounds like an obvious question, but there's got to be more to it. So help us just kind of set the table.
Yeah, I'd say the top issues when it comes to the payers and the concerns that a private practice are going to have. Some of it depends on the maturity of the practice. Is it a startup practice? It's somebody that's been in business just for a few years, or somebody
Mhm.
that's mature in that practice. And also, it's going to be sometimes dependent upon the size of the practice.
Mm.
But when you start looking at what are the main concerns, of course, what are you being reimbursed for? And I'm going to focus a lot on the commercial contracts, because
Okay.
if you're
Yeah.
looking at a Medicare contract, or an MA plan, or getting paid by Medicare, there's
Mhm.
not a whole lot of negotiation that's going to happen there.
Yeah.
None with Medicare.
Yeah.
So we'll be talking about the commercial side. So
Sure.
uh, one of the biggest areas, of course, that you should be looking at is, what is the status of your contract, and actually even knowing what your terms and conditions and your fee schedule are for those contracts. It's surprising. It doesn't surprise me anymore.
Yeah.
Where practices, they don't even have copies of their contracts or copies of their fee schedules.
Wait, that's stunning. Like nowhere
Now,
in the building. That's just good
nowhere in the
Lord.
building,
Good Lord.
nowhere in the building, nowhere in a file.
I want to be
Um,
sympathetic. I really, really do. But
Yeah, and some of it is a matter of, if a practice has been established for a while, they got those contracts maybe 10, 12 years ago, who knows?
mhm.
And you might have had two practice administrators since then. So were they a hard copy filed somewhere, or did they go to somebody's digital email box and it's gone now and
Jeez.
you can't access it, or which is a case that happens on a very regular basis. Did the payer never send you an executed agreement? We see that all the time, even when we're
Really?
helping startup practices. The difficulty of actually getting that executed agreement back from the payer. Some payers are pretty good. You sign your agreement, you send it off, and 2 3 weeks later it gets through their process, and boom, there it is in your email box. While others, we have to go search for them. And
Why? I mean, maybe it's a stupid question, but like, why? You know, I think of I sign something on DocuSign, I can download it right then and there. But I
I think
don't.
some of it, I'm not on the payer side, so I'm unsure of what their full process is. But on a DocuSign, yeah, those sometimes get there, but oftentimes we're sending contracts back that don't go through a DocuSign process.
Mhm.
So we get a hard copy. They'll either want a wet signature. That'll be emailed back through a PDF copy back to a payer rep, who then has to send it up the channels to get signed by either the VP, regional VP, whatever that particular
Yeah.
payer is, and then they just never come back.
Damn.
We will show up. Well, like the practice will show up as a in-network provider on the website 30 days later, but we've got no contract. I can rattle off 6 contracts we're searching for right now for one national company that we're working with, where we've just never received the copies, but we show up as a in-network provider in 3 states.
And so if you didn't make a copy of whatever, then does that mean that you as the provider really don't know what you're getting paid?
Yeah. So if you don't copy down that fee schedule or have access to that fee schedule, yeah, then you could be blind.
Wow. Okay. That's a big area of concern. So any others before we kind of move on?
I think the other part of it is really just kind of understanding. So if you do have the contract,
Mhm.
if where you actually fit inside of the payment. So are you getting paid appropriately to the fee schedule? So you need to do some regular audits and just make sure that the EOBs are matching up to your fee schedule. If you're running a tight ship, that fee schedule should be loaded into your revenue cycle management program, whether it's through your EMR or third party billing, or somebody should be tracking that back. And you should be getting some alerts if you're
Mhm.
not matching that up.
Mm.
Um, because that's a big area where insurance companies, whether it's by commission or omission, will pay a fee schedule incorrectly. They'll get loaded in incorrectly, or something will happen, and you could go for a very long time not realizing that you're getting paid $2 or $3 maybe less than you should be, on your main codes.
Mhm.
Um, those can add up very quickly,
Mhm.
and typically contracts from the payer are written in such a way that you only have a certain amount of time to go reclaim funds that were not done correctly. Now there's some ERISA law and some other things where you could really push that and probably get it paid. It's a struggle that doesn't need to be a struggle.
So code 12345 is contractually arranged at $100 and you're typically getting paid at 96 unless it's up to you to track it. It's funny because, the default, and I'm not in this world directly, but you just think you know, it's all electronic. It's a piece
And
of digital, whatever. How can that ever get? But it sounds like no, I don't know, like it's keyed in wrong or whatever. It's just
right,
Jesus.
and trust me, there are times when we'll go and do an audit and the provider's getting overpaid. They're getting
Ooh,
paid more than their fee schedule.
you never hear
So
about
that's
that.
always an
You
interesting
never think
conversation.
about that. Yeah.
Yeah, yeah. It's like, okay, well, guess what? You need to pay that back, because at some point, somebody at the payer is going to figure out they're overpaying you, and you're going to get a demand letter. Either that, or they're just going to come back and say, "Oh, we're not paying you for the next 3 months because we're going to recoup this off claims."
And so I imagine the contract terms for the payer allow more generous terms of recoupment than it does on the other side, right?
They might be written a little one-sided,
A
yes.
little one side, very diplomatically said. Okay. So what are payers looking for from the practice side?
Yeah, that's a great question, and that's a conversation I have with my providers on a very frequent basis. What we try to do with Healthcare Advisory Network is really we try to think like a payer,
Hmm.
and
God, that
that's
sounds like mental contortions leading to
it
headaches and
can, yeah.
drinking, and I don't know.
Yeah, it can be some days, but it's not that difficult. But you have to think about it from a payer's perspective. What they want is a couple of things. One is that they need to keep their main client happy. So whatever company is paying their bill for their health insurance, they want to keep them happy. How do they keep that HR representative or the CEO of that company happy? Well, you keep the members happy. So you keep the members happy by a couple of things. One is try to relieve as much burden from them,
Mhm,
so they don't have paperwork. They don't have to fill things out. They don't have to sign. And if they make a phone call, in for assistance, hopefully that payer, whether it's a case manager or somebody on the help desk, can answer that question quickly.
mhm,
The other part of it is access. So if a member needs to get into, whether it's a family practice appointment or a specialist, they need access.
mhm.
So payers are always looking for access. Now, from the provider, what they're looking for is, it's not just quality, because quality to a payer should be a given. You should say,
Yeah.
you know what, you're board certified, we got you credentialed, you're in our network. We expect that you're going to have at least this level of quality.
Mhm,
Now, what the good payers are doing is they're saying, okay, now what's that next level?
mm,
Here are some quality incentives. So we've looked at our books and we know that if we're not getting our A1Cs done properly, and we're not getting, blood pressures done, or we're not getting eye checks, this costs us a lot of money.
mm.
So we want to reduce the overall spend. So you know what, provider, we'll pay you a little bit more if you can prove your quality.
As
So
measured by the number of, the for every 10 A1Cs you could do, you do all 10, that kind of thing.
correct. It's
Yeah.
some of it's as most people in practice management and the physician side, they're going to know what the HEDIS scores are. So
Okay.
if you're doing your HEDIS scores and you're doing those things, that's kind of a, hey, this is a standard. You've got to be doing this.
Hmm.
But what's the next level of this? I'm working
Hmm.
with a diabetic endocrinologist right now, setting up her practice, brand new. And we're looking at, okay, what's that next level that we can go back to the payers and show them how much money we're saving them, because those patients are not having to go to the ER or the urgent cares, or back to their family practice physician, for additional workups and everything else, because we're going to manage all of that diabetic piece for them,
Hmm.
and keep them, keep their weight down, all the other things to reduce that total cost of care.
Yeah. I have to tell you, this is like a feel good thing to me because, generally in life, the sooner you tackle a problem, the easier it is to solve. And this sounds like an example of that. I don't know if the economics make sense, but the spirit sounds good rather than waiting for things to balloon and be, downstream where it's just more painful for everybody. It's nice.
Yeah.
Okay. Um, how do you tell what payers are willing to even negotiate? They just seem like these faceless, monolithic, you're not getting your contract and your terms are going to suck compared to ours and blah, 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 blah.
Right.
How do you tell?
Yeah, and frankly, it's over the last, I would say, 12 to 18 months, it's been much more difficult because the payers have done quite a bit of cutbacks themselves. I mean, one of the larger companies, did almost an 11% reduction in force over the last 18 months. A
Oh,
lot of the provider reps and contracts that were or contacts, I should say, that used to be fairly easy to get to, now it's kind of hide the ball. Trying to find those reps, it's
so
sometimes hunting
just somebody
unicorns,
to negotiate with is what you
somebody
mean.
to negotiate with.
Got it.
So what we try to do is keep our little black book of contacts, and try to make sure that we understand who is where. And there's a lot of churn. People move around in companies, but to understand, are they willing to negotiate? Some of it is a matter of what we do with our clients is, when you're building that strategy, one of those strategies is to stay in contact with your payer rep.
Mm,
So if you don't have a regular cadence with your payer rep, you're not going to know when they've left or they've been promoted or done, or their region has changed. So we try to reach out on a frequent basis, making sure that they understand who they are. If the practice is doing something really well, send an email to them and say,
Mm,
hey, we've added this new service, or our patient satisfaction scores just came back and we're 5 out of 5. You can do just easy things. It's just it's basically just business, keeping front of mind. The other area that, are they willing to negotiate? They're not going to come to you and say, hey, let's renegotiate the contract, we're going to
right.
give you more money.
Right.
That does not happen.
Hmm.
So you've got to be on top of when your negotiation window opens up. So if your contract ends on January the 1st, you probably have to notify them 90 to 120 days ahead of time that you want to negotiate. And if you don't during that window, and you decide December 15th that you're getting paid rates you don't like, well, they can say, guess what? Our contract just evergreened, call me
Hmm.
back in September next year. So
Mm,
you got to watch that, because they're not going to be proactive
no,
to say, hey, let's go renegotiate.
correct.
Um, so you and the other, and some of that is, as you track that, you got to understand where your market is at. Know what your contract, do you already have some year by year escalators that were built in?
Hmm.
If you do, they're probably not too willing to negotiate unless you've added a new service. Something dramatically has changed in the market
Right.
for them to agree to open it up
Right.
and get moving on it.
Right. So what they're willing to negotiate, there's something new. You're getting better at something. Like, is there a way to, you're being paid below market, which I guess that means you have to understand where your market's at. Um,
Yeah. Yeah.
yeah.
So what we use is the payer transparency data. So
Ooh,
back
tell us about that. Yeah.
Okay, so 2 or 3 years ago, when the No Surprise Act came out, it really benefited payers to the majority of the No Surprise Act, and consumers also. But one of the areas that was inside of the No Surprise Act that payers frankly didn't like is that they have to, by statute now, put on their website, publicly facing, every contract that they have for payments by either by tax ID number, by NPI, and then by CPT code. So for every contract
Mm,
in the country, we can go into a specific market and pull the data off of the different websites and then compare and contrast what you're making, in suite A for dermatology or whatever
yeah.
specialty you might be,
Yeah.
to your competitor across the hallway that's also a dermatologist in suite B.
Mm,
In the past, I might have known that, but because of contract law, I wasn't allowed really to utilize that, in that
yeah. Yeah.
negotiation,
Yeah. Yeah.
because it was confidential information.
Yeah.
Now it's public information.
Okay.
So we've got our IT team. They go in, they go out to those websites, pull all that data down, and it's literally millions of lines of code, as you
I'll
can
bet.
imagine.
Yeah.
Every CPT code by every tax ID by every NPI for every contract is out there. It's a lot of data.
Is it a well set up database, or is it just you've got to organize?
Depends on the payer.
Okay.
Yeah, it depends on the payer. We're pulling
Then
one
it's
right
by
now for
payer.
Blue
You're right. Oh
Cross.
my God.
Yeah. So
Jesus.
it's structured in a point where basically the law says it has to be machine readable data. So some payers, it's easier to pull than others. And
Hmm.
it's even interesting because some Blue Crosses, because Blue Cross is not Blue Cross is not Blue Cross.
I know.
So some Blue Cross plans, we can pull that data. I don't want to call it easy, but we can pull that data and manipulate it pretty well.
Hmm.
While I've got another one we're working on right now where it's going to be turning cartwheels from an IT perspective to figure
Hmm.
out how to pull that data for that particular state.
Mm,
So, and it's going to be more expensive,
hmm.
but we can then pull that data.
Hmm.
We filter that down. So we'll take the 4 or 5, 6 competitors for the practice we're working with in that general geographic area, that
Yeah.
market area,
Yeah.
and then we lay them out by CPT code and then by payer by plan to figure out, is Dr. Carl getting
Hmm.
paid better or worse than Dr. Adam?
Okay.
And if so, how much is the difference? And at that point, is it worthwhile pursuing, that contract
Interesting.
and
So
to
talk a bit
increase it?
about that, because what's going through my, Dr. Adams' practice is 5 times the size, or there's some sort of extenuating circumstance that explains why Dr. Adam's getting a different reimbursement amount than Dr. Carl.
Yeah, and it makes no sense because I was looking at I
Really?
was looking at an analysis right before this podcast
Okay.
for a mental health provider, and we're looking at the data, and they're a pretty large organization. They've
Hmm.
got 4 offices throughout their region, and they were getting paid 17% less on one of their main codes than a single provider in one office, one provider. They were getting paid 17% less on that one. All of their codes, they were so far below that single shingle, it made no sense as to why in the world, other than they haven't looked at their contracts for way
I was
too
just going to
long.
say, then the single shingle was just more up to it
Yeah.
than,
Yeah.
back to the, where's the contract? What am I getting paid? Don't
Right.
even, didn't even think
Yeah,
it.
and there's sometimes when we're looking at these, and you pull this information and you see a hospital owned group
Mhm,
or an academic medical center owned group,
mhm.
and they're almost always going to be at the top of the list because they've got that leverage from being inside of the hospital system.
And they
And there's
probably got
other
some
deals,
department that's like your job department
right?
is to
Well,
stay
yeah,
on top of this. And right.
yes, and there's also other deals that are going on because if a payer and a hospital are negotiating rates, there's a whole lot of different things that they can move back and forth.
Hmm.
With their ancillaries, you got lab tests over here, we've got our DRG sets over here, so you can move these things around. Sometimes that can actually be to the detriment of the physician group because
Yeah.
sometimes they're the lower on the food chain of that
Hmm.
hospital. So the
Hmm.
hospital may say, you know what, we want paid more as a hospital, and we'll just underwrite the
Yeah.
losses we have on the physician side. But typically, we see those large hospital systems have the higher rate, while the smaller independent groups may have a little bit lower, and then we try to
Sure.
figure out how we can bump ourselves up.
Right. Which makes, I mean, I can get that for the larger, the hospitals, because at least they know what numbers are coming in through which service lines, and they can keep it all together. And if you have a loss leader, fine, as long as you know it and you quantified it and there's no surprises about it. So
Yeah.
yeah. Are there, with, on the private practice side, like, what are the characteristics that you see of private practices that are good about this versus those that aren't? I mean, some of the things we probably hit on, I don't know where my contract is. I do. I've got somebody who
Right.
knows what they're doing. Is it just that simple? Are there other characteristics, like I'm a good negotiator, I'm not? How would you separate those
Yeah.
two kind of profiles?
That's a great
But just
question
to
because
help
usually,
listeners go, do we suck at this, or are we pretty good at this? Or how much better
right.
can we get?
Right. That's a great question because oftentimes, I'm coming in when somebody's got, their hair on fire because, their
Yeah,
reimbursements aren't there.
right.
A consultant usually doesn't get called by a really good practice.
Right. Yeah, although it's
It's just
funny, some of the
some of them
strongest
do because
performers
they
out there are
understand they
like,
need to keep up to date.
yeah, it's like, what am I not knowing? Yeah.
Right. Right.
Yeah. Either
But I
hair on
would say,
fire or I'm awesome. It's all the people in the middle. Be like, yeah, I don't need it.
right.
Yeah.
Yeah. So it really becomes kind of okay. If I say, hey, what's the best practice?
Yeah.
So the best practice is understanding your contract, your terms, understand your fee schedule, making sure your fee schedule is actually integrated into your RCM process.
Hmm.
Look at do an audit of your payments, make sure they're good there.
Hmm.
Double checking on a frequent basis, kind of where you are in the market. Are there competitors that are coming in? Are there new services, other things that could stimulate a conversation with that payer? So
Hmm.
you want to make sure you've got those things covered. The other thing is, making sure you understand, has a larger employer group, switched insurances. Maybe you're getting paid really well from Blue Cross Blue Shield, but your General Motors company down the road just switched
Yeah.
to United Healthcare, and that sucks.
Yeah.
So, and now your payer mix just changed inside of your practice. And do you even want to keep that plan anymore?
Hmm.
And that's another thing that, from a best practice, there are some times where you've got to call the question and not bluffing, but basically say, you know what, payer, we can't continue to do business with you, so we're going to drop you.
Hmm.
And it's a hard decision, especially if you've got a payer that's got a large market share in your region.
Yeah.
They've got power, and you got to keep the doors open. And you don't want to, my grandpa used to say, you don't want to get on the, you don't want the train to leave with any empty seats,
Yeah.
So, you can't, but you also at the same time, you've got to figure out, is it better sometimes to have an empty seat and have a better lifestyle than, basically take
Yeah.
patients that you're getting paid less than Medicare for when
Yeah.
you can just go ahead and fill up with Medicare.
Yeah.
So
Yeah.
that's the things you basically just kind of have to watch that on a frequent basis. The other is making sure that you do have a decent contract management system that's notifying you that hey, it's time to negotiate because it's out of sight, out of mind.
Yeah, you and I have talked about this before. I mean, just the totality of contracts beyond what we're talking about now, your lease, your I don't know what, like, you and I both know people who help practices negotiate leases and how many times like the windows missed and I didn't even know where that was and I didn't even know it was going to
Right.
get renewed and thousands upon thousands of dollars of savings might be sitting. Oh my God. I mean,
Yeah.
just good solid business sense. But what we're
Good,
talking about here is just
good solid contract management pays for
yeah,
itself very, very easily.
yeah,
Because yeah, you've got your lease, but you got everything from your payer contracts to your employment contracts. Having all those,
yep.
um, your waste management lease. I mean,
You name it,
there's tons of them out there.
you
Or those
know?
contracts, and yeah, if you miss those dates, you're out for a year
Yeah.
potentially,
Yeah. I mean, in my world, there's some marketing
or
agencies which
longer
say,
if it's a
"Y-
building lease. You might be out for 5 years.
correct, correct. Um, yeah, like in my world, there's some of us that are month to month. That's what we are. There's others say it's a year and if it automatically renews. And so, yeah, I mean, at least look at them. You might decide to
Right.
do nothing, but at least you've made a decision rather than it being made for you. Um, it really does sound like, as you describe this more and more back to payer strategy, like the skill set you need in a person or a group is just not necessarily kind of off the street. So just a lot of vocabulary to learn, the dynamics of how things work to learn. One of the questions I want to ask you is, do you find that on the payer side, those you need to negotiate with generally, are they good at negotiating? Like
Yes.
that in and of itself, that is not a, I think I'll negotiate that. Like you're gonna lose, buddy. You just
Yeah.
I don't know how bad you're gonna lose. It's a whole
Yeah.
thing.
Yeah. Most of them are trained pretty well. If you get a provider rep that might be new to the game and their job is really just to fill the network up,
Hmm.
what they're going to do is they're going to gather the information and that's going to go up the chain. So it's either
Yeah.
going to go to a director or a VP, and
Yeah.
those people they know the numbers. So
Yeah.
and they also know that what for the I live in Dayton, so
Hmm.
for the Dayton market I have this is my 2025 budget.
Hmm.
Now, if I have a payer knocking on my door and they want a 4% raise or a 10% raise, how much does that mean? How much does that take from my budget? Because they're a company too. They got budgets.
Hmm.
So I'm sure that they've got some, wiggle room
Hmm.
that they know every year they're going to have some negotiations. They're
Yep.
counting on people not to. Um, so, each one of those, they're going to come back and they're going to say, hey, we ran our financial analysis. We can give you X.
Hmm.
Well, I wanted Y. So then it's
Yeah.
where do we fit in the middle
Yeah.
of those two?
Yeah.
So yeah, I've run across some very, very good negotiators. They get trained for this.
Sure. And I didn't plan on doing this plug, but listener, unless you've had some negotiation training, you're not. So think about talking to somebody like Adam once this comes up, because it's just it's you don't just say, oh, it's Tuesday. I think I'm gonna go, oops, we're 3 weeks left. Let's just call them up and negotiate. You're gonna
Yeah.
lose. You're just gonna lose. And
Yeah.
you don't want to lose, you know. So
Yeah.
this is something I would think bring in somebody to do it for you.
Yeah. And the other thing I would add on that, if you do decide to do it yourself, you've got to understand that if you shoot for the moon and the stars,
Hmm.
sometimes they're going to stop the conversation right at the beginning.
Oh
Because
yeah.
if they don't think that you're going to be reasonable in the discussion, then
Yeah.
they're just going to put their hand up and say, sorry, here it is.
Yeah.
So that's why you really need to understand where your market is
Yeah.
and where your value is. So
Yeah.
you got to build both of that into that strategy. Because if you go in and say, hey, you know what? I want a 25% raise this year because my patients are sicker. Well,
Mhm.
guess what?
Me
Everybody
too.
has.
Not going to happen. Yeah.
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 So, unless you've been totally screwed for years,
Hmm.
you're not going to see a double digit increase year over year.
No, there's a lot of analysis that goes into
Yeah.
it. You have to understand both sides, where there's overlap.
Yeah.
Um, you really it takes time. You really have to have a strategy, and it's just
Yep.
not something you can pick up on a Tuesday. So, yeah, covered a lot of ground. Hopefully, we've helped some listeners. Anything you think we should have hit on that we didn't get to?
I appreciate the conversation. The main thing is just make sure you've got a strategy. It's
Yeah,
so simple to put this behind you and not even think about it. I met with a doctor about 6 months ago, and when we showed him what he was actually making on his Blue Cross contract, his jaw hit the freaking desk because
yeah.
he's like, "Oh my God, I'm making less than Medicare. Everybody's told me they're my best payer." I said, "Well, they're not." So you got to understand your
Which is just
numbers.
like a double shocking statement because everybody's told me, dude, you have a contract with them. It doesn't matter what anybody else says. What's your contract with them? That's what you're
Right.
getting. Like,
Yeah.
what do you mean? Other people's opinions about your negotiated agreement are useless. Why would you? Man, oh man. Okay, easy for
Yep.
me to say. Um, so if somebody's, we've caught a listener's attention, this is a setup for the final. We've caught their attention, like, you know what, Adam's right. We just need to get better about this. But this is a very large, daunting thing. Couple simple places where they can get started. I mean, one thing I think of is get all your contracts. Make sure you've got a hard copy of every one of your current contracts. Would that be a good place to start?
That's a great place to start. Make sure you got your contracts,
It's almost too
and
easy
also
though.
make sure when you're requesting the contract that you also request the fee schedule,
Ooh,
because they're not always inside the contract. The contracts might say that you're getting paid a percentage of Aetna's market fee schedule or Cigna's market fee schedule or Blue Cross's fee schedule. Well, what's that tell you if you don't actually have their fee schedule?
yeah,
Nothing. Nothing.
nothing.
So
Okay.
it's not in the contract. It just
Mhm.
tells you that. So you got to go get the fee schedule, make sure that's there. At least United Healthcare, their contracts, they'll right in there, everyone that I've seen, it gives you're getting paid X percent of 2020's CMS and or wherever you're at with that. So at least UHC, it's easy to figure out what their fee schedule is
Okay.
compared to the others.
Okay. Any other places you recommend somebody just to kind of get started down the path of getting a good strategy in place?
I think some of it is, again, understand your market. The other
Hmm.
piece of it is make sure if you're not already figuring out kind of your main value proposition. So what services are you providing that somebody else might not be? Or if
Hmm.
you are providing those same services, are you better than they are?
Mm.
And what's your patient satisfaction? If you can't prove to an insurance company that your patients are happy, then they don't want to deal with you because they don't want the phone calls.
Mm.
So
A-
those are the
a-
things you need.
as measured by reviews online, there's a form each, like as
Well,
measured by
there's a
how?
couple of yeah, there's different ways of measuring satisfaction. Now, a payer rep, and I've talked to them before, where they said, yeah, we went out and looked at the Google site,
Okay.
to make sure that the patients weren't saying bad things about you. So you
Hmm.
got to be careful, the social media side of that because the
Hmm.
payers are going to look.
Hmm.
The other is making sure that you don't have to do everybody that comes through your practice, but do a sampling at least on a frequent basis of saying, you know what, we're whether it's through email or text or the old fashioned going to mail you one.
Hmm.
I don't know if people still do that, but make sure that you are doing some patient satisfaction surveys on a regular basis. That way, when you do start talking about quality and trying to get some additional revenue from a value based um, or bump your percentage on the fee schedule, that
Yeah.
you've actually have some real data in hand.
So you can cook up what seems like a reasonable satisfaction questionnaire on your own, or
Yeah.
is a payer going
Yeah.
to say, no, no, you have to use ours and you didn't use ours. So
No,
that's
no,
okay.
no, no.
Good.
You don't have to. Now, from a Medicare side, if you're negotiating for a hospitalist group, that's going to go through the hospital. So you can use the hospital's Press Ganey
Mm.
information.
Hmm.
If you're a hospital type based group
Yeah.
to do that, but
Okay.
independent family practice or independent specialty group, you're going to need to do your own. And frankly, you probably just go on Chat GPT or Copilot and put in something and get a pretty decent outcome
Yeah.
pretty
On a
quickly.
scale of 1 to 5, how happy were you with the doctors, with the
Right.
nurses, with, 4 or 5? Keep it short, listener. People just, they don't want to spend a lot of time, and almost any
Right.
amount of time is too much time. So just 3 or 4 questions, tabulate them up, keep it easy.
Yep.
Yeah. Cool. Adam, thank you. Thank you for coming on. This is, like I said at the beginning, this is like the mother of all topics. Am I getting paid appropriately on time? How do I do that? It's the opposite of buying things in the grocery store. So thank you for
Well,
shedding some light on this.
I appreciate you having me, Carl.
Yeah, and we're looking forward to more as well. You gave us contact information, which we're going to put in the show notes of this episode. So anybody who wants to get a hold of you has another way to do so. A couple of quick points before we wrap up. First, if you're someone like Adam or I and you serve private practice owners, or if you're a private practice owner yourself and you've got some experience on the business side of private practice, please, we want you to come on Practice Care and tell the world about it. In the show notes for Adam's episode and every episode, there's a link, a couple of clicks, takes you less than a minute. Just tell us what's on your mind and we'll get you scheduled as soon as possible. And finally, Practice Care, one word, please subscribe. Apple, Spotify, wherever you listen to podcasts, we're easy to find. We drop a new episode every week, and that's the easiest way to stay up to date. Thanks very much, and until next time.